Hello, everyone, and welcome to the Arthritis Action Podcast. I'm Mark, as always, your host, and today I'm joined by Professor Weiya Zhang. Weiya is a professor of epidemiology, Faculty of Medicine and Health Sciences at Nottingham University, with a special interest in arthritis. So, hello, Weiya.
Hello, Mark.
Nice to meet you. Thank you very much for joining us today. The topic for today is one that I'm personally really looking forward to. I think this is going to be a really interesting talk. And it's a very tricky subject. So obviously I wouldn't dare tackle this one on my own. So I'm very happy to have you here to unpack this with me. So we're going to be talking about placebos and the effects that they can have on arthritis, which is, like I said, I'm quite excited about this one. So before we jump in, I've given my usual very brief bio of you, but for all of our guests listening, I'm sure they'd like to hear a little bit more. So if you could introduce yourself in a bit more detail and tell me about your experience and interest with arthritis.
Thanks, Mark, for your invitation. My name is Weiya Zhang, and epidemiologist from the University of Nottingham, as Mark already introduced. I'm very interested in arthritis, and recently we have done some researches into placebos and placebo response and effects in people with osteoarthritis and other types of musculoskeletal conditions. And it is great honor for me to be able to share some of our research with you.
Excellent. Thank you. Thank you. So I thought to kind of help frame this topic a little bit more, I think maybe it would help to talk a little bit about pain and its treatment first, so that then we can kind of understand where a placebo would come into play afterwards. So maybe if you could start off by telling us how people with arthritis perceive pain.
Well, that's a really good question, Mark. As we all know, medical science actually evolved from biological model to biosocial psychological model. However, many of us actually still stay on the biological model. So whatever we got, the problems, we try to find whether there's an underlying sort of structure change. And we actually did a very nice interview study recently, and 50 patients had been interviewed. And they all got osteoarthritis, and we just try to see their perceptions about their pain, about their joint conditions. And the majority of them actually still thinking about it is a condition with biomechanic problems on knees. So I think that is still stay on the biological model. But as we all know, pain really is a problem not only for the joint, but also related to pain center in brain activities, reactions of the stimuli. So it is quite complicated condition. It's not only structure change, but also the brain change. I remember in Oxford some years ago, a professor did a very nice study, just try to see the size of the brain between people with pain, chronic pain, and also people without pain. So they find actually the brain is much bigger in people with pain. So that means their brains also try to cope with the pain for the long time. Therefore, the size and function of the brain all change. So that actually brings up another question. Pain is actually the condition in a person, not only just under the joint.
Okay, excellent. So what would you say are some of the more conventional styles of treatment for pain then?
Well, there are minor analgesics such as paracetamol, ibuprofen, and there are also some moderate strength painkillers such as steroid injections, and also opioids as well. That's very strong analgesics. But for osteoarthritis pain, it's not really on either side, minor and severe pain. But most of the people actually with pain between these two extremes. So it's a moderate pain, but it's really, really disabling.
Hmm. So it's more just the main sort of treatments for pain are sort of medicine based, then I suppose, the more conventional treatments at least.
Yes, if I think that there's a sort of ladder we go for when we're talking about first line drug, first line treatment, second line treatment, and also third line treatment. I think for people with pain, we normally recommend non-pharmacological, like exercise. Just try to see whether exercise would strengthen the muscle, and then once the muscle strengthened, and the stability of the joint will be improved. Therefore, they will have less pain. So I think that has been confirmed by many, many randomized control trials. If exercise really doesn't work and we move on to first line drug treatment, at the moment it's paracetamol and topical NSAIDs. If still cannot control their pain, we move on to joint injections, steroid injections. If all these failed, the last one we can do is just joint replacement.
Okay, great. So also we're big fans of like the exercise route for that as well. So glad to hear that that's always one of them, as that's one of our sort of regular bits of advice we always like to give as well, as it's so beneficial to so many people.
Indeed.
Excellent. So what I suppose were more of the I don't know whether to go into the unconventional treatments of it as well. We don't need to go too far into that one because obviously I want to get to our main topic. But are there any kind of like more unconventional ones that are out there that aren't perhaps widely approved or evidence-based, but are quite common?
Well, for chronic pain, is really, I think it's challenging for every one of us, especially for GPs. So many of patients actually go to complementary medicine as well.
Mm,
So, such as acupunctures and herb medicines and so on. But these are all, apart from acupuncture, and all of them have minimum evidence, randomized control trial evidence to support.
mm.
But many of the patients feel really effective for them. So we'll come back for that, why they feel really very, very effective. So in the conventional way, there are some treatment, although randomized control trial haven't really confirmed they are better than placebo, but they're still being widely used, especially in other countries, not UK. For example, like glucosamine and also chondroitin
Mm.
sulfate, and the intra-articular hyaluronic acid injections. I think these are the treatment quite widely used in other countries. But in UK, it is not recommended as part of the NICE guideline because we don't have sufficient evidence, randomized control trial evidence to support they are better than placebo.
Let's jump into it there then. Like as we mentioned placebos a couple of times now, so let's get in there with let's start off real simple. What is a placebo?
Well, this is a historic question, really.
Yeah, it sounds simple, but I knew it wasn't going to be.
Placebo actually, right at the beginning, this word is not from English. It's actually Latin words.
Okay.
What does that mean? Is actually I would please. So I think that is what exactly it is. So I
Okay.
would please rather than here. That was about 1700, so central at that time point. So we didn't have any effective treatment. We just try to comfort our patient, please them, and then their pain will goes away, and some of the symptoms for other conditions will goes away. It's really try to comfort our patient and massage and take care of them. But afterwards, the first time placebo come into the modern science is 1945s, when the first drug, streptomycin, it was developed by MRC here in the United Kingdom. And people just thought we need to confirm whether streptomycin is good, it's effective for tuberculosis. We need to have a comparator.
Hmm.
So, and what comparator we should have? It's actually placebo. So before that time point, because we all use placebos, sugar pills, bread pills. Now let's develop a new pill. Exactly looks like streptomycin tablets in terms of size, shape, color, and randomize into our patients. So some of them receive streptomycin, and some of them receive this inert, we call it inert placebo. Just try to see whether they're different. I think that's the modern science. Just try to bring this standardized treatment into place to confirm any new development, any new drug would be better than that in order for us to approve it.
So I suppose I hadn't really thought about the fact that all randomized trials, essentially,
That
half of the
was
people will be having a placebo in that, won't they?
Yes, that was the first time we actually bring the placebo into the development of our new treatment. Anything has to be better than that in order for us to approve it. So I think that's placebo, the second sort of arrow, which is bring placebo into the randomized control trial. And afterwards, 10 years later, 1955, a scientist, Beechers, called Beechers, and he actually find many patients actually respond placebo per se. So even if you give them the INOT pill, and then they still respond, especially for those with painful conditions. And that bring placebo into back to the practice again. Say, well, shall we use a placebo? Continue use a placebo in clinical practice. But obviously, once randomized control trial been developed, and it was not allowed ethically.
Right. Okay. I see. I mean, so you've done a lot of research into placebos, haven't you?
Not much really. We have done
Oh,
things.
sorry.
We started, we started from about 20 years ago, and we are interested in placebo because we find placebo really in clinical settings really quite effective. Not only because of Bishop's study, and find 35% of people actually respond placebo. And we just thought it would be very good if we can actually confirm whether placebo is effective or not in osteoarthritis. So one of the most common arthritis in this area. So that make us started this research. I think first we actually started as a sort of what we call the meta-analysis, just combine all randomized control trials. So those with placebo as a comparator and also those with placebo as a treatment. There's no treatment group. And we just try to see whether placebo, first of all, whether placebo per se is better than no treatment group. And we find it is indeed from 198 trials we gathered. And we find it's very effective. The effect size is moderate, actually. It's fulfill nice, clinically meaningful, important difference threshold. And then that will make us think about the placebo itself in trials is effective actually for people with pain due to osteoarthritis. And we also went into what are the determinants for this. We find the severity of the pain is one of the predictors. The severe pain you have got, and the more responsive to placebo you have. And also another factor is actually needle is better than pills. So if it's a needle placebo, which will make better than better than pill placebos. So, and we also find in trials, if a placebo goes with a strong analgesic, placebo effects would be higher than those placebo in trials with the active treatment, which is a moderate strength of analgesic. So, and it's not only for pain, it's actually for functions and stiffness as well, but less effective for more objective measures such as the circumferences of the knee. So if the knee's circumferences is bigger, it doesn't really matter for placebo effects. So and the quality of life we didn't pick up any as well. And that actually suggests placebo probably more effective in subjective outcomes.
Okay. So actually, this is something that I kind of really want to know then. It's like, I'm not really sure how to phrase this. Like, either how or why does a placebo work?
Yeah, this is a very good question. We are still investigating really how it works. And from now on, we find it works for pain, as I said, more likely for subjective outcomes. But our another studies, injection studies, which is randomized control trial,
Hmm.
we try to compare steroid injection, intra-articular steroid injection with intra-articular silent injection, which is a placebo group
Hmm.
for pain due to osteoarthritis. We didn't find any difference, not only for pain, but also for synovitis, so local inflammation of the joints. So, and they are similar in terms of the pain relief and also inflammation. So, and we also look into placebo effects in more broad sort of spectrum of the diseases, like rheumatoid arthritis, which is very different from osteoarthritis.
Excellent. I mean, can placebos be harmful in the sense that I'm more thinking along the lines of if someone is taking something that is a placebo, could that then be a detriment to them because they're not taking real medication or rather like, evidence-based medication?
Well, this is a really good question. Like any other treatment, placebo also cause side effects.
Hmm.
So what we call nocebo effects. So nocebo effects, especially expressed in the randomized control trial when placebo was used as a comparator. So, for example, in our studies, we find placebo to ibuprofen in the trial compared to ibuprofen in the trials. So, when ibuprofen actually cause abdominal pain, placebo also raise the risk of abdominal pain as well. So, and these two groups almost there's no difference between that. And when we use the placebo as a comparator in opioid trials, we also find placebo cause constipation, so which is a common side effects for opioids. So this has been observed. Therefore, we give the name called nocebo effects
Hmm.
for side effects because of placebo.
Okay. So when these people are, let's say, randomized trials like that, does that mean that they kind of know what to expect for the side effects from it? And so they get them because they're just told they're going to get them? Or is this still randomized and they just all appear to have the same side effects?
Yes, Mark. When you run the randomized control trial, you have to ask patient to sign the informed consent.
Mhm.
So what does that mean? That means we would have to tell them what we are going to use in this trial. For example, one called ibuprofen, another called placebo. Yeah, but you will be randomized to these two treatment, either of them, not both of them. So the chance of getting one is 50%.
Hmm.
Yeah. And you would have to tell them what are the beneficial effects, what are the side effects. So as you can see here, because they got 50% chance of getting ibuprofen, when we tell them ibuprofen will cause nausea, dizziness, abdominal pain, or even gut bleeding. And certainly they will think about, oh, if I got that one, I would have that problem.
Yeah.
So their expectation for that side effects would be higher than the normal people who are not involved in the trial.
From all of this, do you think there's a benefit to people having placebos then?
Yes, as we have discussed, Mark, in trials, we find placebo is actually better than no treatment control. So,
Okay.
so as you can see here, it's non-blinded, isn't it? Once you
Hmm.
use a placebo pill with a comparator called no treatment, that means the patient got no treatment. You can't blind it. Therefore, there are some sort of bias there because of non-blinding. We call it open open trials.
Mm.
So they may have some sort of overestimation of the placebo effects. However, in real world, it's as it is, isn't it? If you
Mm.
give the treatment or not give the treatment, no matter whether it's a true analgesic or placebo, it's always, it's you're always looking into whether I give this treatment and the patient pain will reduce by half or quarter. So that's what you're looking for, isn't it?
Yeah, for
In
sure.
the real world. So I think it is what we call the pragmatic trial.
Mm. Okay, I mean, can like a placebo stop working if someone is aware of them? Like if you give someone a placebo and tell them that's a placebo, would there be any change to how they feel or how they respond to it?
That's really excellent question. So
I don't know if anyone's bothered to do this or not.
coincidentally, someone called Ted Kapchuk from Boston University he's actually a very good placebo researcher. And he did a very nice trial in irritable bowel conditions. He thought about that, Mark.
Mm.
He thought about if I tell patient this is a placebo and what is called and what it contained and what we have got so far for placebo, whether there's any benefits or not for irritable bowel syndrome. By that time, we already find from trials placebo works for irritable bowel syndrome.
Mm.
And then he told them, he said, this is placebo. Now I'm going to give it to you randomly. And you got 50% chance to get onto this placebo. And it is placebo. Historically, it's trying to please you rather than hear you.
Yeah.
So, but according to current evidence, it shows some signaling, which is effective for pain. Okay. And
Wow.
then, or you've another 50% chance you will get nothing. So, and what he got is actually placebo improves disease-specific outcomes for irritable bowel syndrome and also quality of life.
Wow. Here's another one for you then. So can like say let's use someone with arthritis, for example, like someone with osteoarthritis, can having a placebo actually have a physical effect on them? Like, can it actually, repair any damage, or can like the body start to regenerate, or can anything like that happen where it's actually what you would expect from an actual medicine? Can that happen from a placebo, almost like just from the power of someone's perception that they're on real medicine?
Not as far as I know in arthritis area, because arthritis, especially my area in osteoarthritis, at the moment we don't have disease-modifying drug yet,
Mm.
which confirm better than placebo yet. So although glucosamine sulfate and chondroitin sulfate has been developed as a disease modification drug, but unfortunately, once we got a very good trial and with large sample size, properly randomized and blinded, we couldn't really find it is better than placebo. So I don't have that structure modification effects for placebo yet
Mm.
in this area. And most of the placebo research is actually in the more it's complex in disorders like osteoarthritis, not only structure problems, but also the whole sort of body problems. So I think we do need to investigate further just to see whether there's any structure modification effects for placebo. But if you consider, Mark, that inflammation is part of the structure, I think I can tell it changed.
Mm. Okay, that's interesting then. Right. So this is one we touched you touched a little bit upon this quite much earlier on in the episode, and I was wanted to talk a little about the almost like the ethical element of prescribing placebos to people. So like, I mean, it sounds like one of my question originally was going to be, like, are placebos knowingly prescribed by doctors? But it sounds like, of course, in a randomized trial, that would be the case. But yeah, is there any like ethical concern if someone's to do it outside of a randomized trial? Like, if a doctor were to give a patient a placebo as their medication, does that happen? Is that a real thing?
Well, this is excellent question, Mark. Again, I think um, you wouldn't believe, there, um, in fact, so many people, so many practitioners actually use placebo in practice.
Okay. Tell
Um,
us more.
um,
Tell us more.
a survey really find about 17 to 100% physicians in the world prescribe at least once either pure placebo or impure placebo to their patient. The average, on average, is 50%.
Wow.
Unfortunately, from this survey, I haven't got UK data, but I think it's probably around that sort of.
Yeah, I mean, from the start, I still imagine, like, I mean, like what you were saying with vitamin C and everything, like, again, there's no harm in doing so. So, and if it makes them feel like they've got something, there'll be that positive benefit from it, won't there? In the fact, even if it's only a mental one that, okay, I've got something for this now.
Yeah, it's almost like it's like a supplement, really,
Mm.
to active treatment in China. I think they still do that.
Well, it's an eye opener, that one, I think, isn't it? So
Yeah,
that's,
yeah,
I wonder how many people actually have thought about that before.
yeah. So it's not only whether physician prescribe, it's actually there's an over-the-counter placebo, which is called Obicup. So
Okay.
have you heard about that, Mark?
No, I don't know that one.
Obicup, it's the placebo writing reversely. It's Obicup.
Oh, of course. Oh, I'm being very dense here, aren't I? Of course it
Yeah.
is.
It was on the shelf. Yeah, it was on the shelf in New York pharmacy, really. I saw that. So,
And you can
and
actually buy that, and you can just buy that.
yeah, yeah, it's over the counter. I think this has been very widely sort of disseminated in other countries, not only US.
Hmm.
So the reason they put it in reverse, it just try to sort of tell people this is a placebo. Actually, we don't really know what it works.
Yeah. Covering their backs essentially, go, well, look what
It's
we've
up to
called
you
it.
to
Well,
choose. Yeah,
of course it didn't work. Look what it's called.
yeah.
Oh, that's really interesting. Wow. Is there anything else you wanted to talk about on this, by the way, as well? Anything? Because we've gone through my list, but I was wondering if there's anything else you wanted to cover that you come up with while we've been talking about.
Yeah, I think probably what we are concerned, I'm sure you're concerned as well, is really how can we really deliver placebo in practice without challenging with ethics.
Yes, the ethical standpoint of
So
it.
I think ethical issues definitely, if we know someone, according to the current ethic standards, is that if we know someone mm, something doesn't work for a condition we targeted on, it is unethical to use it, to prescribe it. Um, we have in my group have been thinking about the next step. How can we move forward? I think if we can come back to the nature of the placebo, nature of the placebo is actually something we have already come across. It's part of any active treatment. It's a vehicle, or we called context of therapy.
Hmm.
So what is the context of the therapy? What is the vehicle contain? The vehicle contain personnels like GPs or any other specialty specialists or nurse, and the environment and the way we deliver the treatment, and all these we call contextual factors. So that I think our research uh, uh, has found placebo does works. And in order to move forward, we needed to go back to understand the nature of the placebo. The nature of the placebo is actually the composite of the care, a good care. It's the way we deliver the treatment. It's the context of the therapy. And therefore, shall we improve this context in order to enhance the treatment effects? So that's the angle I'm getting into it. Therefore, we come up with a new development. We would like to develop a contextual enhancement package,
Okay.
which including being a good doctor,
Hmm.
so including provide a good environment and provide sufficient consultation time. Overall, it's just try to really do a proper examination, provide sufficient information, something like that. We have already started that.
Okay.
Yeah. So we have identified 8 elements which are very important for this package. We aim to trim it down further. So I think this would be easy to pack together. And hopefully we can do a feasibility study first and then randomized control trial plus minus this contextual enhancement package to see whether we can improve treatment effects. I think that's the way ethically would be very nice to support sort of deliver placebo. So I think in order to do that, we probably need to switch from placebo to contextual therapy. So not really using placebo in words because there's a bias for this. People always think it's a trick of mind. It's actually cheating. So it's not. Actually, being a very good doctor, give the sufficient time, provide sufficient information and good care to our patients, examine him, not just come and go, and you just talking to the screen and then not really spend the time face to face to do a good consultation with your patient. Our modern medicine guru, William Osler, already said, a good doctor treats the disease. A great doctor treats a patient with disease. So I think that is something which we all need to really improve, I think. That's the lesson I have taken.
I think that's a great lesson. That's a wonderful one to end on as well, because I really like that note. I think excellent ending quote there. So we'll stop it there. Thank you so much. So for all of you listening, if you would please do like, follow, subscribe, review the podcast, wherever you get it from. If you'd like any more information on the stuff we've been talking about, or, please do visit our website. There's a link in the episode description for that. Also an email address should you want to contact us about anything at all or anything we've been talking about, or even any, future episodes you'd like to hear. Do let us know. We'd love to hear from you. And Weiya, thank you so much. That has been absolutely fascinating. I've really enjoyed that one. You've absolutely delivered.
Excellent questions.
Thank you. My pleasure. And thank you everyone for listening. Bye bye, everyone.